and the credit goes to blood bank for arranging so many units of RH negative blood. After 2 days, the patient got stable and was shifted back to gynae department and discharged on 9th post-operative day in satisfactory state. Pre and post-operative counseling is very important step of the management was done by senior gynecologist, anesthetist, and senior member of Tahir Heart Institute team. Thanks to Almighty Allah for saving this patient, and management would not be possible without the prompt help of anesthesia department of Fazl Umar Hospital and ICU team of Tahir Heart Institute. Thank you.
Thank you very much, Dr. Nusrat Majoka, for the miraculous recovery of the patient with multidisciplinary treatment and active participation. Now, for the next, our next presenter is Dr. Munawar Arai. He is the professor of the ophthalmologist. He is retired now from the Lakhar Medical College. Dr. Munawar Arai Sahib. His topic of discussion is the role of rifampicin in central nervous system chorioretinopathy.
Assalamu alaikum. This year I was not prepared to make any presentation, but one message came to me on WhatsApp from Rabwah, and that message was a picture of or image of OCT of a Muallim Sahab. He suffered from this problem, and nearby he was not able to find out any treatment. So they sent this message to me. After that, I decided to make presentation of this topic because we have done research on this topic, and this research is published in a very good journal. इसकी स्लाइड का चेंज करने का यहाँ से इधर से ठीक है थैंक यू. So the objectives of this study was to evaluate the effects of rifampicin in central serous chorioretinopathy and to diagnose and document changes in the retina by OCT. OCT is optical coherence tomography. Central serous chorioretinopathy, it is detachment of central neurosensory retina from retinal pigment epithelium, and it occurs due to accumulation of subretinal serous fluid. Usually involves one eye of young healthy male ranging between 30 to 50 years, and male to female ratio is 3 to 1 average, and variation may be 2.3 to 1 and 6.6 ratio 1. The patient presents with decreased vision and metamorphopsia. Metamorphopsia is change in the image. The image is distorted, and because this central sensory retina is detached, it comes a little forward. So patient becomes hyperopic, and vision usually remains with 636 to 69. And there is induced hypermetropia, and patient improves with small plus lens. So risk factors are stress, type A personality, endogenous or exogenous steroids, respiratory tract infection with Helicobacter pylori. I don't know whether this is mentioned in the literature. So pregnancy and untreated hypertension. Diagnosis of CSCR is made by clinical examination on slit lamp. You will check visual acuity and slit lamp examination. On Amsler grid, you can check what is happening with the image. If it is distorted, it is, there is metamorphopsia, micropsia, or usually there is macropsia. So OCT is the main diagnostic tool that we used, although other tools are used, but nowadays it is very confirmative. So we have used OCT. We are also, previously we are using nowadays, even these are using fundus fluorescein angiography, indocyanine green angiography. So clinical course, it may resolve spontaneously within 3 to 6 months, usually acute type. 50% of patients have recurrence and 15 to 20% progress to chronic form. The treatment modality is that in acute form you can observe for up to 6 months and it may resolve. Oral spironolactone, this is a potassium sparing diuretic. It was also used, but it is not purely a treatment. Laser, a low pulse micro spot laser can be used. It induces some inflammation where the leakage point is, and after that it heals and problem is resolved. Then PDT, photodynamic therapy, was also used. Intravitreal anti-VEGF, these are also used. Case reports of aspirin and beta blockers are also, patients have shown that this is also effective in some cases. The reason for how this CSCR is produced, as glucocorticoids are implicated in the development of CSCR, glucocorticoids inhibition with the rifampicin has been suggested as a potential treatment modality. Rifampicin, an antibacterial drug widely used in the treatment of tuberculosis and leprosy, is known to induce cytochrome P4503A4. Rifampicin can effectively overcome CSCR by inducing catabolism of endogenous steroids. Now this is a OCT picture of normal retina. With OCT we can make cross-section of retina in a living person, and result comes in seconds. So just take a picture and the result is like this. You can see all layers of the retina. This is the normal picture. Methods of study. Study was conducted at LAM Hyderabad. Total 31 patients of 30 to 40 years with idiopathic CSCR were registered. Idiopathic CSCR was defined as a localized neurosensory retinal detachment associated with focal leakage at the level of retinal pigment epithelium. Patient with evidence of serous elevation secondary to other ocular conditions such as optic disc pit, multifocal choroiditis, posterior scleritis, choroidal mass or associated systemic illness were excluded. Approval by ethical committee, and unaided, we then examined the patient thoroughly. Unaided visual acuity was done, slit lamp examination, OCT, LFT, oral, and then we started oral 300 milligram of rifampicin for 3 months with a monthly review. Because this drug is hepatotoxic, so that is why we, before treatment and during treatment every month, we performed liver function test. The rifampicin is an antibiotic that has been used in the treatment of tuberculosis. The drug induces cytochrome P450 enzyme in liver involved in the metabolism of endogenous steroid by rifampicin. The basic mechanism involved in improvement of CSCR. The role of rifampicin in CSR was introduced by Ravage and Pecco when they found resolution of CSCR in a patient with tuberculosis. This was followed by first ever case report published by Senley NC. At that time, they used 600 milligram rifampicin, and it resulted in liver function problem, and then they stopped and abolished this treatment. But we used 300 milligram, and that was quite safe. And nowadays, even we have reduced this dose to 150 milligram, and there is no any risk for liver function abnormality. So the 38 eyes of 31 patients, 24 males, 7 females, and 7 patients had bilateral involvement, while the rest were unilateral cases. 14 were right and 10 were left eyes. 1 patient had CSCR with pigment epithelium detachment. Liver function test of all the registered subjects were within normal range before starting the treatment, and there was a little change after treatment. Visual acuity before starting the treatment 624 to 612, while after treatment it was 660 to 69. And frequency of distribution was that male 24, 70% and female 22%. Laterality, right eye 14 and left 10 eyes, bilateral 7 eyes. Type primary 23, recurrent 22.6%. Blood group were O positive 8 patients, 25.8%, B positive 20 patients, 64.5%, and A positive, they were 9.7%. Now this was a case, this patient is in Tharparkar. Married person, and it has a long-standing or chronic recurrent CSCR. You can see this is the first. This is the first picture when he came to us, and this is central serous chorioretinopathy with pigment epithelium detachment. And after 3 months, this CSR, this was treated, and only this pigment epithelium detachment, it was left. And after, it looked longer time than the CSR itself. And after more than 6 months, only this portion, small portion was left. This is the pigment epithelium detachment, this area. So, and after 8 or 9 months, patient was completely all right. Now, this patient, this is a female patient from Sevan Sharif. Patient is diabetic, hypertensive, and 10 years back she was given anti-VEGF intravitreally. At that time she felt better and improved, but after some time again it was a recurrent. You can see it started again. The same condition started again because patient was hypertensive and diabetic, so it was very difficult to treat with this. But with the grace of God, this patient completely, she became normal after 4 or 5 months. Now, what happened to this patient after treatment? After 3 months, patient developed anterior uveitis and increased intraocular pressure, and we have to give anti-glaucoma treatment and non-steroidal anti-inflammatory drugs. But with the grace of God, now she is completely all right. Now, this patient was male, married, single marriage. So this patient was female, and her husband has done another marriage. So in first case, the male was in stress, and in second case, the female was in stress. So stress is the main cause of CSCR. So हम ये दुआ करते हैं कि घरों में शांति रखें, ठीक है, ताकि इस किस्म के प्रॉब्लम्स ना हो, बल्कि कोई भी प्रॉब्लम नहीं होता अगर आप अपने लाइफ, घरों में लाइफ जो है ना वो ठीक रखें. So conclusion is that rifampicin 300 milligram is effective and safe in the treatment of central serous chorioretinopathy without causing any systemic imbalance. So this was the picture which was sent to me. ये है जी Tahir Ahmad साहब शायद, he is मुअल्लम, and we have started treatment 3-4 days back, inshallah, with the hope कि ये भी inshallah within 3 months he will be okay. Thank you very much.
Thank you very much. Thank you very much, Professor Munawar Rai. Now our next presenter is Dr. Alia Ahmed. She is the professor of hematology working in the Children's Hospital, Lahore for the many years. She is always helpful for us for the diagnosis and the treatment of the patients. Dr. Alia Ahmed, his topic of discussion is early diagnosis of the childhood cancer, why it is important in low middle income countries. Dr. Alia Ahmed.
Assalamu alaikum. Jazakallah for allowing me to present this. I'm a professor of pediatric hematology and oncology in Children's Hospital, Lahore, University of Child Health Sciences. And I want to present upon the... oh, sorry, अच्छा यहाँ पे भी आ रही है, यहाँ आ रही है. अच्छा नहीं आ गई है ना, ये भी लगी. हाँ जी, thank you. So I'll be talking about early detection of childhood cancer and why it's important in low middle income countries like Pakistan. I did not attend yesterday's lecture, but I heard from the previous speakers that the main theme is awareness. So awareness has two parts, awareness for the public and awareness for the providers. So I think we have more of the providers here. And I feel it very essential that our providers should know that when they should suspect that the child is having cancer, because our children are suffering because of a paucity of detection skills of healthcare providers, that the next child sitting in front of them can have cancer, because it's a myth in our culture that we don't suspect a child having unusual system that he can be having a cancer. So this is one of the slides I took from my MSc thesis, which I did from 2020 to 2022 from St. Jude Children's Hospital on global child health. And this slide shows that for a population of 220 million and from 0 to 14 years, we have this one. We have more population from 0 to 14 years. And for this, we estimate that every year in Pakistan, almost 10,000 to 11,000 children, they get cancer. And if you see this table, that the leading centers who treat childhood cancer from Children's Hospital Lahore to Shaukat Khanum, Aga Khan, NICH, CMH Rawalpindi, only 4,000 kids, they reach the hospital. So 6,000 to 7,000 children, they are never diagnosed, they are never suspected, and they die at home or on the way to hospital. So this is a very gloomy picture for a large country. There are very few centers, and many of the kids, they die because they are never diagnosed for childhood cancer. So this is the purpose of my talk, that for our healthcare provider, they should suspect children. I mean, at least they should have in mind that the next child sitting in front of them being consulted can have cancer. So this was one of the study we submitted for in our COP Congress 22, I think. And this shows that the parents, they are very good in detecting that child is having something wrong. And they bring the child to the hospitals within 1 week in 72% of cases. But when they come to the hospital, the doctors are very sluggish to make decision that the child can have cancer, and many of them are referred to the tertiary centers after 1 month. So this is opposite. So I think we need to create awareness among the providers than the public, because the parents are good enough and they find that something is wrong with the child and they bring to the hospital, but the healthcare provider, the doctors, nurses, whoever is there, they take much longer to bring the child, to refer the child to tertiary hospitals. And in Pakistan, unfortunately, we don't have many good referral networks, and I think many of you have experienced this. Once we suspect a child having cancer, we don't know where to send except for Shaukat Khanum Hospital, who cannot take the load. So this is very obvious. And then the current picture of childhood cancer is very gloomy, because every day 1,000 children, they get cancer, they get diagnosed with cancer. And 80% of the children living in high-income countries, they get cured. But only 20% of children living in low-middle-income countries, they get cured. So it's 20-80. 80% are living in LMIC, but they get cured only 20%. So this is a very, very sad situation. And to tackle this problem, WHO and St. Jude Children's Research Hospital, I am a student from that hospital, they took the initiative in 2018 in one of the UNO sessions that something should be done, and that initiative is called GICC, and we are Pakistan also a member of as a focus country, and many projects are being done. And they wanted to do something better, that every child everywhere has a right to get treated, to live and die without suffering. So this project, maybe you can Google and you can find that the main key stakeholder is St. Jude Global, St. Jude Children's Research Hospital, Memphis, USA. And they have funded WHO, I think, millions and billions of rupees and technical help to do this project. So these are the pictorial view that if a child is living in US or Canada or Europe, only 1 out of 5 will die, and 4 out of 5 will be cured. But unfortunately, if a child lives in low-middle income countries like Pakistan, only 1 child out of 5 will survive, and 4 out of 5 will die. So this is a very sad situation. But the problem is our policymakers are not, they don't have any vision to change the situation, unless the international stakeholders come and they help us to change the current situation. So you also can see this is the cure, and high-income countries, they're 80%, and slowly it comes down to low-middle-income countries, it's 20, 10, 20, and 30%. And they have found out that there are many avoidable things which can bring the increased cure. And the first step is lack of diagnosis. Because there are steps in the treatment. Any treatment has steps, like neonatal sepsis, if you don't bring the child in time, he will die. And even if typhoid, if you don't bring the child, you don't suspect, he will die. An adult, healthy adult can die because of a typhoid rupture or everything, a complication. So for childhood cancer, lack of diagnosis, misdiagnosis, because many of these children, they are being diagnosed for typhoid, malaria, arthritis, and back pains, and especially for, I want to create awareness about brain tumors, because we are seeing the suffering every day. Child who's a very small child complaining to the parents that he has headache, he has vomiting, and they are being treated for, well, we have a very honorable gastroenterologist, Dr. Mahmood here. Maybe he has been seeing patients for children bringing by parents with severe vomiting, and sometimes they are being endoscoped and later they turn out to be brain tumors. So this is, my talk is about creating awareness among everybody who is here, that please, 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 if you suspect any child with unusual symptoms, you should refer. And if we diagnose them in time, we can treat them in time. And so this is the, this picture shows that only 20% of the countries in low middle income countries, they have programs who encourage and the campaigns among the healthcare providers and the public that how to treat children. And Africa is going very good because there are many, many campaigns, and Central America also. And only 3% of countries in these regions, they have referral networks. So when the GICC, St. Jude Children's Research Hospital, along with WHO and other stakeholders, they initiated this project, that is GICC. They said that by 2030, we want to improve the survival from 30% to 60%. And they want to reduce the suffering for these children. And by 2030, and they wanted to do it everywhere in the world, because everybody knows the politics, the political instability in these countries is very difficult. So this is one of the projects of WHO GICC, that is called National NCCP ICAIA, and this is National Cancer Control Planning and Integrating Child and Adolescent and Young Adults. And these are the series of workshops that are being done online, and I think more, sometimes 30 countries or 40 countries, they are being selected from all over the world, and then they participate in the training for how to write and how to develop and implement the National Cancer Control Plan. And fortunately, I was the lead last year also, and for the lead for this year also, and there is one oncologist from each hospital, like Shaukat Khan, Aga Khan, and other hospitals. So hopefully, by these training, we can carry forward. So how to train the healthcare providers for red flags of childhood cancer? This is very important. I think I'll be distributing some handouts also for how to look for the red flags. So this is one of the Saint Silouan, this is from the South African team who developed this. Silouan is this, they have Saint Silouan is, I'm not sure there's some, there's saint there, so they developed saint. S is to seek. It means that if any symptom which persists, please seek the help. And I is for E by E, that if anything happens like leukocoria or some other quick symptom, please go and check for B scan and MRI brain and orbit, because retinoblastoma is treatable. And lump is, I think it's as equal to adults, because any lump, whether it's a child or whether it's an adult, it should initiate the investigations. And U is for unexplained. Any unexplained fever which remains for 2 weeks or more, or there's weight loss, or chills, pallor, bruises, that child should have go to pathology and go for CBC and everything. And aches and neurological signs I already mentioned. So one of the study we did just last year, that is knowledge, attitude, and practices among healthcare providers. It was done among, I think, 6 hospitals from Lahore. And just wanted to see that what is their knowledge and what is their attitude and what is their practices for childhood cancer. And it was a cross-sectional studies, and 316 doctors and nurses participated. And these are the results. I just wanted to show that majority of them were the pediatric medicine PGRs doing FCPS and then FCPS surgery, and then the pediatrician and the others. And we find that 77% had good enough knowledge, and they have positive attitude that childhood cancer awareness campaigns should be running in the country and should be expanded. And then we can see that 86%, they said, we did suspect childhood cancer, we did treat and referred and treated the children. So this is a very good picture, but I think this is among the test-free healthcare pediatricians who are going to be pediatricians mainly. So we concluded that overall knowledge was good towards early detection, and we should have training programs for, actually my thesis project is based on this, and I'll be training the community health workers also. And this is one of the, this is Grace Kelly Childhood Cancer Trust is from UK, and then they developed these small red flag signs. And this can show, cancer is concern, anorexia, number of attendance. If the child is coming again and again to clinics, please look for cancer, and complexion, whether he's having pallor or bruises, exhaustion, and other symptoms. So this is my talk. Thank you very much.
Thank you very much.
It brings some awareness about the early detection of childhood cancer. I hope for it, because we, the oncologists, also see the gloomy and sad stories every day, because children are not being brought in early stages, and almost 80 to 90% are brought in stage 3 and stage 4. Thank you.
Dr. Alia, for the informative, alarming, and eye-opening for our doctors. Now, our next last presenter is Dr. Mr. Samar Ahmed. He is a consultant orthopedic surgeon working in the hospital, and working in our Fazlamar hospital for the last 14 years. Now he is working as the head of the department of orthopedics.
Thank you very much, Dr. Wahid, for the introduction. My topic of my paper is audit of handwritten medical prescriptions in an outpatient department of multi-specialty hospital. What is a medical prescription? It is a written medico-legal document by a physician for patients, pharmacists, and nurses. If misinterpreted at any level, can lead to wrong treatment. Prescription errors can lead to medication errors. The background is prescription audit is a part of a medical audit. The purpose to evaluate the prescription practices of medical practitioners. Our objective was to study the handwritten portion of prescriptions in outpatient department of a multi-specialty hospital in Rabwah. The electronic portion was not included because it is a system generated and little chances of any mistake. It was an observational study from January 2024 to February 2024. A total of 400 prescriptions were randomly selected from OPD of 8 different departments, 50 prescriptions from each department. Inclusion criteria: the carbon copies of prescription sheets of patient visited OPD during study period. Only consultants and medical officers doing the OPD where prescriptions were included. Exclusion criteria is poorly eligible prescriptions, prescriptions of house officers, prescriptions written by other doctors on behalf of consultants. These 8 departments were included. The variables were presenting complaint or history. It was 70% prescriptions contained and 30% didn't mention it. Duration of symptoms were written by 65% possession. Clinical examination was only written by 40%, and only 20% clinical diagnosis was made on the prescriptions. Medical doses much better, 80% doctors wrote the medical doses, and duration of treatment was only 30%. And the next visit was only by 20% doctors wrote went to have a next visit to the patients. In case of a referral, only 20% of the doctors give the reason to refer the patient to other departments. And signature of 90% doctors did their signatures to the prescriptions, and 10% even didn't sign their prescriptions. This is the department-wise distribution of the variables. Just want to show some prescriptions. This was a prescription advised in our OPD, in OPD of a hospital. No diagnosis was made. Patient was advised to have a syrup called Rex, 2 teaspoonful TDS, या T what? In Urdu, maximum number of our patient doesn't know the abbreviations or English. 2 chamach subah dopahr sham, even didn't try to write it whose chamach is required, tea, table or whatsoever. This is another prescription. Patient presented with headache, vertigo, and the treatment advised only on the stat orders. Even the columns advised by the Public Health Commission was not pulse temperature was recorded. Take home message, we should be careful while writing our prescriptions. Thank you very much.
Thank you very much, Dr. Samar, for our eye-opening. Now it is the time for the shield distribution. I'll invite Dr. Majoka to present the shield to Dr. Alia, and Dr. Alia will present the shield to Dr. Majoka. Because of the time is strained, Nasabala is coming, so it is better that we should conclude it. Now I'd like to ask Dr. Nasir Ahmed Malik Sahib to present the shield to Dr. Daud Salim Sahib. Dr. Nasir Ahmed Malik Sahib. Dr. Daud Salim Sahib. Dr. Mirza Samar Ahmed Sahib. Dr. Sahib, please. One more. Thank you very much.